Alzheimer's disease and related disorders, right? Everything that we know about this is that age is the greatest single risk factor. The Alzheimer's Association estimates that at age 85, about 40% of older adults will have Alzheimer's or related disorders. But of course, this means that 60% of those individuals do not develop Alzheimer's disease and related disorders. And so our research really started focusing on asking the important question, why? And so there's a number of models of risk. And for example, now it's about 2 years ago, the Lancet Commission released this really nice model looking at the lifetime accumulation of risk factors that can lead to Alzheimer's disease. And so it's clear from that there are things we can't control. We can't control age, sex, family history, or genetics. And that probably makes up about 60% of the attributable risk. But that means that about 40% of the attributable risk are things for which we have some control over, right? And so we became really interested in trying to understand, can we build a better brain? And so as we took this to its next logical step, this led us to the concept of resilience and vulnerability, right? So we know that there are genetic mutations that can explain the really rare forms of ADRD, but it's much more difficult to explain this in the typical sporadic case, right? So ultimately, we came down to the question, why are some people more resilient than others, and why are some more vulnerable than others? And really, there's no one single risk factor that can explain this. So it's probably a very complex interaction of the things that make our brain healthy or put our brain at greater risk. And so this was the etiology of us creating this brain health platform. If we think about all the things that we know that are modifiable and non-modifiable risk factors, we figured out that we would first determine how to measure these things. And I often joke when I talk with people, this is how I spent the global pandemic, right? Is trying to figure out how we could actually measure these things. And so this led us to create some new instruments. So the first one we created was a very simple test to determine cognitive performance. And so most brief tests that are out there are very heavily weighted toward capturing memory problems. But in fact, memory problems are not necessarily the earliest sign of a cognitive disorder. And memory is mostly affected in Alzheimer's disease, but not in other brain diseases. So in vascular cognitive impairment, Lewy body dementia, frontal temporal degeneration, traumatic brain injury, multiple sclerosis, memory is not the key feature. So attention and executive function is. So we created a brief tool called the number symbol coding test, which allows us to quickly, in 90 seconds, get a sense of someone's overall executive performance. And their performance on this test corresponds very well with their global cognitive abilities. So we had our first piece, right? We're able to measure cognition, an important component of cognition affecting all of brain function in a brief period of time. So now we have our measure of brain performance. The next step was to measure brain resilience, right? And so resilience means the ability to resist the effects of age and disease. And so we looked through the literature and through our own data and tried to come up with some aspects of this. And so we created something called the Resilience Index. And this is made of 6 factors. So the first is cognitive reserve, which basically is how strong someone's brain is over the course of their life. And so we created a scale, the cognitive reserve unit scale, that looks at the contribution of education and occupation, right? So in mid to late life, your lifelong education and your lifelong occupational attainment can give us some measurable scale of how strong your brain is, right? The second is physical activity. Changes in physical performance may be a harbinger of future impairments. And this has been demonstrated by many research groups, including our own. So we created a brief scale called the Quick Physical Activity Rating Scale, which combines intensity, frequency, and duration across 10 different activity categories. So now we can estimate a dose of physical activity. The next is mental activity. So just like physical activity, mental activity is very important. And people who have lower levels of mental activity appear to be at a higher risk for developing disease. So we created a scale called the Cognitive and Leisure Activity Scale, which does the same thing. It allows us to create a dose of cognitive activities across 15 different categories. And then we added in 3 additional measures. One is how socially engaged people are, what they eat. So we use a score sheet that's based on the MIND diet, which is a combination of a Mediterranean diet and an anti-hypertensive diet. And then the last is a measure of mindfulness. So this is the ability to live in the moment, not let the weight of the world bear down on you, to be self-reflective. And so this is an important sort of spiritual aspect of brain health, right? So we combined cognitive reserve, physical and cognitive activities, social engagement, diet, and mindfulness into a resilience index. And this gave us a measure of brain health. And then the last thing is, if we measure brain health, then what gives us a sense of what's happening in terms of brain disease? So then we created something called the vulnerability index. And we used machine learning techniques to identify 12 factors, 4 non-modifiable factors and 8 modifiable factors that were most closely associated with the risk of cognitive impairment. And so this is a weighted scale and includes age, sex, race and ethnicity, education. Those are non-modifiable. And then frailty, obesity, depression, and vascular medical conditions, diabetes, stroke, heart disease, hypertension, and cholesterol. So we put that together, and that gave us a score of the risk of brain disease. So now that we are able to measure brain performance, brain health, and brain disease, we combined all of these together in what we call the brain health platform. The number symbol coding test takes about 90 seconds. The resilience index takes the longest, and that takes about 5 to 7 minutes to complete the surveys. And the vulnerability index is a checklist that's just basically pulled out of the medical record, or could be just done as a checklist. So that's another 3 or 4 minutes. So in roughly 12 to 15 minutes, we're able to get a complete assessment of a person's brain health. And so while all physicians can diagnose Alzheimer's or MCI, it's much more difficult to assess the status of someone's brain health and identify those at risk for impairment, particularly the first time you meet them. So what we did was we put all of these things together, right, to have a comprehensive assessment of overall brain health that could be done in less than 15 minutes. And what we found was that we were able to carefully and clearly discriminate healthy controls from people at risk. Within the at-risk people, we're able to differentiate people with MCI from people who have Alzheimer's disease or related disorders. So we can place each person sort of into a probability cloud at the first time we see them and determine whether their brain is healthy or not, and if they're likely to have MCI or Alzheimer's disease. And what's really, really interesting and important about this is that if you're a healthy control, there are people who are true healthy controls, right? So that they have healthy brains, they're unlikely to develop disease. But there are also healthy controls whose brains may be low on resilience and high on vulnerability. And so these people are at a very high risk for transitioning to cognitive impairment. Likewise, within the MCI group, there are MCIs who are very stable and are unlikely to progress very fast. and there are MCIs that are much more likely to progress to dementia based on their vulnerability and resilience. So this allows us then to take a very personalized approach to prevention. Primary prevention for the healthy controls and secondary prevention for the MCI group. And I think this is what's really unique about the project. In 15 minutes, first time I meet someone, I can basically say whether your brain is healthy or not, and how likely it is you're going to progress, and have actionable targets to develop a personalized prevention plan. So we developed this in one sample that was a cross-sectional sample. So we're now doing this in a longitudinal fashion to see if these baseline predictions hold up to be true. And then we're incorporating biomarkers now, so both imaging and fluid biomarkers, so that we can understand these baseline scores, what's the correlation with underlying pathology. So we're looking at MRIs, looking at volume and white matter disease, amyloid and tau PET imaging, and then plasma and genetic biomarkers of multiple pathologies, so that we can stage each person and understand not only are they likely to change, but that likeliness of change may be attributable to an underlying pathology. And again, the idea is, can we do this to increase eligibility into a clinical trial? Or the clinical application is, could this be used in a geriatric clinic, right? So each older adult coming in can do 15 minutes of assessment, and we can tell them, you're likely to have a problem. Let's do something about it now, rather than waiting for you to have a problem and reacting to it.